would invite our next speaker, Dr. Gumbs, to tell us about what progress we're making in prostate cancer.
Hi, good afternoon. I'm just sharing my screen now. Can everyone see my screen?
Yes,
Yes.
we can.
Okay. My name is Shellie, Dr. Shellie Gumbs. I'm an internist at Memorial Sloane Kettering. Sorry. I'm an internist at Memorial Sloane Kettering, where I work with the medical management of surgical cancer patients. I'd like to thank the organizers for having me here today to speak about this topic. This is a roadmap of, sorry, something keeps popping up on the screen, I apologize. All right, so this is a roadmap of my talk today. I'm gonna go through everything from epidemiology straight through to diagnosis and ultimately treatment. First, I will start with a video that reviews the anatomy of the prostate.
The prostate is a gland found only in men. It is about the size of a walnut and is located just under the bladder. The prostate gland surrounds the urethra, the tube that carries the urine to the outside. The prostate helps with sexual function and makes some of the fluid that is found in semen, the liquid that is ejaculated during male orgasm. Prostate cancer develops as small nodules or bumps in the prostate that can often be felt by digital rectal examination. The cancer usually grows slowly and it can cause problems with both urination and sexual function. The tumor can remain in the prostate for many years before spreading to other parts of the body. So it is important to get regular checks before it spreads.
Okay. Okay, epidemiology. Prostate cancer is the second most diagnosed cancer in males in the United States. It accounts for approximately 29% of cancer diagnoses. 1 in 7 males will develop prostate cancer at some point in their lives. In New York City or New York State, approximately 16,000 cases of prostate cancer are diagnosed each year, and about 10% of those will die from the disease. Worldwide, there are 1.4 million new cases of prostate cancer annually, and the mortality rate in the United States have declined. So from 39 per 100,000 to about 19 per 100,000. Models have suggested that PSA screening could account for about 45 to 70% of this decline. Another reason for the decline is advancement in treatment modalities, which we will discuss a bit later. So the epidemiology of prostate cancer in the Caribbean. Caribbean men have a higher risk of prostate cancer than any other population of men in the world. They were found to have a higher incidence and mortality rate. Reasons for these discrepancies include misperceptions about the disease, lack of regional guidelines, and poor access to healthcare. This all results in worse outcomes when compared to those in high-income nations. And as an example, in Jamaica, 304 men out of 100,000 are diagnosed annually. And remember on the last page, I noted in the US, it had declined to 19. So if you want to use that as a benchmark, you can see the comparison. In Barbados, 160 men out of 100,000. And in Tobago, 10% of adult men were found to have prostate cancer annually. And this information was from the NIH from March of 2022. So what are the symptoms of prostate cancer? 1, decreased urinary stream, where the flow of urine is not as strong as it used to be. Urgency, which is the inability to hold one's urine. hesitancy, where you have difficulty starting and stopping the flow of urine, nocturia, which is waking multiple times at night to urinate, and incomplete bladder emptying, which is the sensation of still having to use the bathroom despite the fact that you have just done so. Note that these symptoms are nonspecific and they may present with other disorders. For example, an enlarged prostate, which is also known as BPH, benign prostatic hypertrophy. So risk factors for prostate cancer include 1, age. The older you get, the more likely you are to develop prostate cancer. Next is race. It is more common in Blacks. The age of onset is also lower in Black men, and the cancer tends to be more aggressive in Black men. Next is diet. Studies regarding diet have been mostly observational, but as Dr. Graves just described, a lot of the same factors contribute to prostate cancer. A diet high in animal fat and low in vegetables have been implicated. Smoking history. Smoking affects both the risk of getting cancer as well as the prognosis of cancer. Family history, obesity, and genetics. And there are mutations such as BRCA1, BRCA2, which is associated with breast as well, and Lynch syndrome that are known to increase the risk of prostate cancer. So how do we screen? These are the screening guidelines for prostate cancer. In average risk males, screening should begin at the age of 50. Men who are known or likely to carry genetic mutations, such as BRCA1, BRCA2, or Lynch syndrome, are at an increased risk, and screening discussions for these patients should begin as early as 40. For the other males at higher risk for prostate cancer, and this is where Blacks come in, and those with a family history of prostate cancer, screening discussions should start at 40 to 45 years. It is recommended that screening be stopped around the age of 70 or sooner based on an individual's other medical conditions and the life expectancy of that individual. Okay, so regarding the digital rectal examination, we just spoke about something similar in colorectal. I added this here because it incites a great deal of anxiety amongst men. As noted in the photo, the procedure involves inserting a gloved finger rectally to palpate the back and the sides, which is posterior and lateral parts of the prostate gland. Although most cancers are located in this region, PSA screening detects cancer way before they become palpable. And therefore, the DRE, digital rectal examination, is no longer recommended as a screening tool. The PSA remains the gold standard. Benefits of screening: early detection, which will lead to earlier access to treatment, and subsequently a decline in mortality. And there are some drawbacks of screening as well, such as overdiagnosis. Some cancers are very slow growing, and they may never progress in an individual's lifetime. The question then becomes, do we need to diagnose these individuals and expose them to unnecessary treatments? It has also been reported that 30% of men in their 50s and up to 70% of men in their 70s who have died from other causes were noted to have prostate cancer postmortem. So this remains an ongoing debate. Lastly, there are false positives. PSA can be elevated for a number of reasons. Even riding a bicycle can transiently increase PSA levels. So this can lead to a lot of anxiety. And there's also risk of prostate cancer treatment, which is not completely benign, so there is some risk there. Screening for prostate cancer is performed using a blood test called the PSA, also known as prostate-specific antigen. It is a protein that is produced by both normal and malignant cells. A PSA of greater than 4 is considered abnormal. There are some nuances there, depending on age and medications, etc., when interpreting PSA values, but in general, 4 has become the accepted cut. Men with a PSA between 4 and 10, which is considered borderline, have about a 25% chance of having prostate cancer. If the PSA is greater than 10, the chance of prostate cancer is more than 50%. Note that there's no set PSA cutoff point that can diagnose prostate cancer with absolute certainty. The reason that PSA is not 100% conclusive, as I mentioned before, is because various other things can cause a rise in PSA level. As you get older, your baseline PSA level increases. Having an enlarged prostate, as I mentioned before, an infection of the prostate can increase your PSA level, having certain urologic procedures, and even medications, and riding a bike, as I mentioned. Prostate cancer is diagnosed using a needle biopsy by performing a needle biopsy. During the procedure, 12 core biopsies are taken from various areas of the prostate. There are currently 3 approaches to biopsying the prostate. 2 of them are shown in the photograph here. One is the truce biopsy, known as transrectal ultrasound guided biopsy. So as its name implies, the biopsy is performed going through the rectal, by the rectal area. The second is the transperineal approach. That's this one here. The perineum is the area located between the rectum and the scrotum. So the scrotum will be somewhere here. And lastly is an MRI-directed biopsy. And this is still being studied, but the belief is it may replace the standard transrectal approach. So after a biopsy is performed, the samples that were obtained are then sent to a pathologist who determines both the diagnosis as well as the severity of the disease if it is present. The severity is reported as a Gleason score, which is on the picture you're seeing here. And then it usually is resulted as a number between 6 and 10. So a score of 6 is considered low grade, which implies a slow growing tumor that is less likely to spread or metastasize. Excuse me. A score of 10 is considered a high grade tumor and is most likely to spread to other parts of the body. So if you look at the Gleason pattern here, 1 we consider well differentiated, right? So these are pretty, this is just a depiction, of course, but there are some abnormal cells in here, but these are pretty close to being normal prostate cells. And you can see as the Gleason score increases, the cells become more and more abnormal. So by the time you reach level 5, they no longer really look like normal cells. So as the Gleason score increases, so does the risk. All right, treatment options. So there are now multiple options available for prostate cancer treatment. The choice of treatment is determined by how advanced the cancer is. That is whether it is confined to the prostate, i.e. localized, or if it has spread to other part of the organ, to other organs, which is metastatic disease. So for localized disease, we have observation, which we also call active surveillance. This is the recommended treatment for cancers with a Gleason score of 6 or lower. And remember, I just said that Gleason score of 6 are considered slow-growing tumors, and usually they do not need to be treated right away. Some of these cancers may never actually need to be treated. So these patients are followed with blood draws, monitoring the PSA, rectal examinations at intervals, and repeat biopsies also at intervals. Another treatment for localized disease is surgical removal of the prostate, which is also known as a radical prostatectomy. The next two are forms of radiation therapy. This can be performed in two ways. One is external beam radiation, where radiation is transmitted from outside of the body, targeting cancer cells. The next form of therapy is brachytherapy, which is where radioactive seeds are placed within the prostate tissue. These seeds deliver a low dose of radiation over a long period of time, thereby killing the cancer cells. Next are freezing and heating of the prostate tissue. So freezing is also known as cryoablation or cryotherapy. This involves using a very cold gas to freeze the tissue. It is then thawed and the process is repeated. Heating of the prostate tissue, called high intensity focused ultrasound. This uses concentrated ultrasound energy to heat the prostate tissue. Both heating and freezing causes the prostate tissue to die, thereby killing cancer cells. Next is hormonal therapy. So testosterone is considered as food for growing cancer cells. So the way hormonal therapy works is either by stopping the production of testosterone, and that an example of that medication will be Lupron, that's the brand name, the generic is Leuprolide, or blocking the testosterone from reaching the cells. And the most famous of that one is bicalutamide or Casodex. All of these treatment options, as I mentioned, are for localized or locally advanced tumors. Treatment of metastatic disease, chemotherapy, which uses drugs in either the intravenous, which is IV through a line, or pill form to kill rapidly dividing cells. And the next option is immunotherapy. And this uses the body's own immune response to fight cancer cells. So normally your body does not fight cancer cells because the cancer cells produce a protein that helps it to hide from the immune system. So immunotherapy interferes with that process, either by genetically engineering your own immune cells and putting them back into the body to fight cancer, or by helping the immune system to identify cancer cells so that they can be eliminated. So this slide I took, this was from an NIH article that was published in March of this year. And the title of the article was Prostate Cancer in the Caribbean, a baseline assessment of current practices and potential needs. So I showed the practice guidelines and treatment options available for various islands. If anyone in the audience have more information about the statistics in Barbados, but these are what I found. So screening in Barbados does not have a formal screening program. Please correct me if I speak incorrectly, but from what my research, I didn't see one. In other islands, you can see opportunistic. So what opportunistic means is that you go to the doctor and the doctor takes the opportunity basically to test you. So it can be in two ways. It can either be patient initiated, where the patient comes in and says, I want to be tested for prostate cancer, or screened, sorry, or the doctor, because you're in the office, takes the opportunity to discuss it with you. There are 4 urologists in Barbados, and I apologize, I'm a little biased if there's anyone in the audience from other countries. So urologists are physicians that specialize in the diseases of the urinary tract. So it's not just prostate, it includes kidney, diseases of the kidney and the bladder as well. Oncologists, there are 4 in the island, and oncologists are cancer specialists, doctors who specialize in treating cancer. I didn't really, CT imaging is available. It's available in a lot of the islands as well. I didn't really get into CT imaging, but the way we figure out if there's metastatic disease is usually by doing a CAT scan, a CT of the body to see if there's disease in other parts of the body. We also do MRI to see, and bone scans in the case of prostate cancer, because prostate tends to like bone, so it metastasizes to bone frequently. So there is CT imaging, there is chemotherapy available, and this is radiation therapy. External beam radiation therapy is what that stands for. So there is radiation therapy available. So this I took from the Barbados National Registry for Non-Communicable Diseases. And this was also published in March of this year. It shows the number, percentage, and rank of the top 10 cancer sites in Barbados. So you can see prostate cancer here. Rates have pretty much been consistently. This ends in 2018. But remember, early in the talk, I gave you the statistics for 2022. But the rate is above 20%. And we spoke about births earlier, so you can see those numbers there, and colon as well. So the top 3 actually. All right, so in conclusion, prostate cancer is one of the leading causes of cancer in men. It is more prevalent, occurs at a younger age, and tends to be more aggressive in Blacks. The one takeaway I would like you all to have from this talk is the importance of PSA screening. If you are a man, approach the topic of testing with your doctor. If you are a doctor, please be opportunistic in your testing. And if you are a woman, encourage the men in your life to get screened.